It's always a pleasure to do this for this particular group because I know that, we take care of a lot of patients with cancer and survivors of cancer, but I always feel like the survivors of cancer are the most motivated to really take care of their own health and their own well-being. And so it's always a pleasure when Katie and her group ask me to do something like this because I'm always inspired by people that want to kind of take ownership of their own health. So hopefully by the end of this, I will have gone through a bunch of different important pieces of information that you can then kind of take back to your own medical team, your own doctors, and your cancer team or your survivorship team, and it will kind of empower you to take better care of yourselves, and also to empower you to have questions to ask of your cancer team. So with that, I'm going to start. I think probably best to leave questions until the end, and then I think there will be plenty of time for questions. So I made the title of this Cardiovascular Disease in the Modern Cancer Survivor: What Patients with Cancer Should Know About Their Heart Journeys Throughout the Cancer Journey. And as Katie mentioned, I am at NYU as the director of the Cardio-Oncology program here, though I am also a heart failure cardiologist. So I sort of have this unique expertise where I get to see patients along the spectrum. And a lot of the patients with cancer that we see don't have heart failure, obviously, but my expertise sort of dovetails in both of those specialties. So objectives for tonight's discussion: I'd like to review the background and the scope of the problem of cardiac disease in survivors of cancer. I'd like to help you understand how cancer treatment can affect your heart. And I'd like for you to be able to take away simple ways that you can protect your heart health after cancer. So first, you need to know some facts. So the facts about cardiovascular disease in survivors of cancer: more patients are surviving cancer than ever before, and heart health is a really important but kind of a lesser known part of survivorship. Many different treatments can affect the heart, and they can affect the heart while you're getting treatment, but they also can affect the heart over a long period of time throughout the rest of your lifetime. And heart disease winds up being the leading cause of illness in survivors of cancer. And what you may not know is, compared to people without cancer, adult survivors of cancer have significantly higher cardiovascular disease burden, especially heart failure, independent of regular traditional risk factors, which we will go through. What you also may not know is, when you look actually at data and statistics of what patients with cancer wind up actually dying of later on, when they're not dying of recurrence of cancer or cancer itself, they're actually most likely to die of diseases of the heart and vascular system. So we really need to be paying attention to this, particularly in people who have survived cancer. What we know is that there are many types of cancer where it is very likely that people already have pre-existing heart disease. So you can see here in the purple, with hematologic disease, that is like leukemias, lymphomas, multiple myeloma, with lung cancer, breast cancer, colon, kidney, head and neck cancers, and many other types of cancer. You can see in the purple, it will tell you the percentage chance that people with that particular cancer diagnosis have coexisting cardiovascular disease. You can see here that the most likely patients to have coexisting cardiovascular disease, for example, are lung cancer patients and kidney patients. But really across the board, we know that many cancer patients, when they get the diagnosis of cancer, already have pre-existing heart disease. And while I'm not going to go into the details of this slide, I always feel like it's impactful to show this slide to patients, because there's a whole list and a whole armamentarium of cancer drugs that oncologists are using depending on the type of cancer that you have. And almost every single one of them can touch the heart or have a cardiac complication or a cardiac issue as part of their side effect profile. So while I certainly don't expect you to know even the names of what I'm talking about here, suffice it to say, if you have gotten a cancer therapy, chances are that one or several of the cancer therapies that you got during the time that you had cancer may affect the heart at the time you're getting it, or may affect it over time. And that's where sort of cancer survivorship really comes into play, and really understanding what treatment you got and what your risks actually are. We also know that there is a growing population of cancer survivors. So I told you, people are surviving cancer way more than they did several decades ago or even a few years ago. And it's actually estimated that by 2040, there will be 26 million survivors of cancer. And we know this to be true, especially sort of in the baby boomer age range. And so you can see here on the left in the green and in the purple, people ages 65 to 85, really there's a huge and growing population of cancer survivors of those ages. And obviously, as you know, those ages kind of predispose you also to cardiovascular disease. So we know that this is a huge issue that we need to pay attention to. What you also may not know, and I personally, as a cardio-oncologist, find to be pretty fascinating, is we think that there's actually a bi-directional relationship between cancer and cardiovascular disease. So it's not just that if you have cancer and you get some type of cancer therapy that increases your risk of cardiovascular disease, but actually it's like a two-way street. So we think of it as if somebody has cancer, there's probably inflammation in your body, there's probably other factors that we are only beginning to understand now that might increase your risk of cardiovascular disease, even setting aside the risk of the cancer therapy that you're going to get. So maybe there's something about the cancer itself and the systemic inflammation associated with cancer that increases your risk of having heart disease. And vice versa, people that have existing heart disease are at increased risk of getting cancer. And we, again, don't really understand this in its deepest sort of form, but it is important to know that it's sort of a two-way street. If you have cancer, you're more likely to have heart disease. And if you have heart disease, you're more likely to have cancer. So we also know, and I think really what I'll wind up spending most of the time on, and what we spend most of the time on in my office with patients, is talking about the fact that many cancer treatments have side effects that affect the heart. So what do I mean by this? Well, again, I don't expect you to understand sort of like the really particular details, but in a very general sense, we know that some chemotherapy and other cancer drugs can weaken the heart, and that's something called a cardiomyopathy. And you may have heard, or you may know people that have a cardiomyopathy or heart failure. We also know that certain cancer drugs can actually increase your chance of having high blood pressure or even having coronary artery disease or blockages in the heart or even heart attacks. We know that certain cancer therapies, and particularly in people that have had radiation in the past, they can actually have increased chance of valve disease. The valves are like the doors that kind of separate the different chambers of the heart, and that's where the blood goes through. So you may know people that have valve disease, and cancer patients with certain treatments can have an increased risk of this. And we also know that many cancer treatments can cause issues with heart rhythm disturbances, and we call those arrhythmias. So things like atrial fibrillation, atrial tachycardia, sinus tachycardia, ventricular fibrillation, ventricular tachycardia, prolongation of something called a QT interval, which is something that your doctor might see on an EKG. So a lot of different cancer treatments can cause arrhythmias as well. So what you're looking at in this chart here, and again, you may not know, is that there is a very big association between patients that have survived cancer and cardiovascular disease based on the type of cancer that a person has. So if you're not used to, doctors are used to looking at these charts, but if you're not a science person, you may not be used to looking at a chart like this. So I'm just going to orient you a little bit. So what you see sort of here, you see that they're looking here at 12,000 patients with any kind of cancer. And then what they do is they tell you how many of each kind of cancer. And so what you're looking at here is sort of a plot that tells you what the likelihood is that a person with any kind of cancer would have cardiovascular disease. And then it sort of breaks down based on the type of cancer. So for example, if you have any type of cancer, you are 37% more likely, 1.37 times as likely to have cardiovascular disease than someone of your same age, as your same sex, as your same race, as your same educational level, and a lot of other factors, your smoking status, everything else being matched. If you look otherwise exactly the same as a person who didn't have cancer and you had cancer, you are 37% more likely to have cardiovascular disease than your non-cancer counterpart. And you can kind of see going down the list, breast cancer is 32% more likely, prostate cancer is 10% more likely, lung cancer is the worst. Lung cancer patients have a much higher chance of cardiovascular disease. colorectal cancer, and certain types of hematologic cancers, like I told you before, myeloma, lymphoma, leukemia, etc. And this is sort of another way of looking at that study. This is a different study when they looked at cardiovascular risk in people that survived cancer. And what they looked at was a registry of 91,000 people that had survived cancer. And they actually compared that to 450,000 plus patients that were cancer free. And they followed those people in that registry for over 5 years. And what they saw in a nutshell was that patients with cancer that survived cancer were much more likely to have cardiovascular disease. So you can see here broken down, more likely to have atrial fibrillation, more likely to have heart failure or cardiomyopathy, like we talked about, more likely to have diseases of the valves or diseases of the muscle of the heart. And here, I know it's hard to see this, and I don't expect you to kind of look with a fine-tooth comb, but believe me when I tell you the solid lines here. So for example, if you looked at ischemic heart disease, which basically means blockages of the arteries or coronary artery disease, you could see the solid purple line is the people that had lung cancer, and the dotted purple line somewhere here is the people that didn't have lung cancer. And the people with lung cancer, for example, had a much higher cumulative risk over the 5 years of follow-up to have cardiovascular disease, and so on and so forth. Prostate cancer in particular, I think, is important to talk about. I actually saw 2 prostate cancer patients in clinic this afternoon that were actually seeing me. They were sent by their oncologist because prostate cancer in particular, these guys are known to have a lot of modifiable risk factors. So this was a study that actually looked at uncontrolled cardiac risk factors in prostate cancer in men, and almost all of them had at least one risk factor that could be modified, like high blood pressure or diabetes or high cholesterol or overweight or things like that. And we know that men with a history of cardiovascular disease, when they get a prostate cancer diagnosis, are even more likely to have a problem with a cardiac complication. So I'm just giving you one example of one type of cancer, but we could spend the entire night talking line by line about each kind of cancer and what the particular risks are. So it's nice that I kind of gave you the background. So now you know that there is a pretty big scope of the problem. But once we recognize that heart disease is a major issue in survivors of cancer, what can we do about it? Because it's always nice to know that there could be a problem, but if you don't know what to do about it, it almost means very little. So I'm going to go through kind of a step-by-step approach of what I think is a pretty simple way to think about this. So let's start with step 1. Step 1 is understanding whether you are a person who your doctor would even consider to be high risk. So this list that I'm about to give you is by no means comprehensive. There are other things that make people high risk, but these are kind of the big ticket items. Are you an older person? Did you have a history of high dose chemotherapy, or did you have radiation to your chest? Let's say you were a lymphoma survivor, a Hodgkin's lymphoma survivor, and you had radiation to your chest when you were a teenager or a kid or a young adult. Are you a person that has pre-existing heart disease? Did you have a heart attack in the past? Did you have heart failure in the past? Were you ever hospitalized for anything having to do with your heart? That might make you higher risk. Are you a person who has other heart risk factors? Do you have high blood pressure, diabetes, high cholesterol? And also just other certain types of cancers themselves. Like, for example, I told you patients with lung cancer and patients with kidney cancer are at particularly higher risk. So if you have a higher risk type of cancer, maybe you would be considered higher risk. And did you have particular treatments as part of your cancer treatment protocol that would have made you high risk? And a lot of you may not know that, but it's totally reasonable for you to ask your doctor. Did I have something as part of my cancer care that would put me at high risk of having heart disease now? So I always tell my patients, whether they're patients with cancer or survivors of cancer, or they're my heart failure patients, or they're just general cardiac patients, there are certain things in your medical history and your medical profile that you can control, and there are many other things that you can't. So nobody is ever going to be able to help you control your genetics, your family history, your age, whether you're menopausal or you're premenopausal. None of that we can control. But there are a lot of things in our medical profile that we can control. For example, our alcohol consumption, our weight, our blood sugar levels, our blood pressure, how we eat, what type of diet we eat, our amount of physical activity, our cholesterol levels, whether or not we are continuing to smoke or we have stopped smoking. And so these things are really, really important to think about, because hopefully in the next few slides, I will show you that if we can take the things that we can control and well control them, we are going to very much decrease our risk as survivors of cancer, to decrease our risk of cardiovascular disease now or in the long term. And as they say, and it holds true here more than I think in many other spaces, an ounce of prevention is worth a pound of cure. So as much as we have really great ways to cure cardiovascular disease or to make cardiovascular disease better, I would much rather see a patient in my office where I can talk about prevention and give them strategies and techniques to decrease their risk so that they actually don't develop cardiovascular disease. So that brings me to step 2, which is to really be proactive about lowering your risk. So how do we do this? So this kind of gets back to that last slide that I showed you about modifiable risk factors. So it is really important and cannot be overstated to stay physically active. So I always tell my patients, at minimum, you should be doing at least 20 minutes of some moderate exercise a day. And honestly, I don't even care what it is. If you want to go out for a brisk walk, if you want to go to the community pool and swim, if you want to do Pilates in your house or go to a class, if you want to do your Peloton, if you want to walk with a friend or jog with a friend, whatever you want to do, 20 minutes of it a day will do the body good. A heart healthy diet, think the more of your plate that is made up of plant-based food, and the more that is not processed and not high sugar and high cholesterol and things like that, the better. So I really try to make a half or 3/4 of my own plate plant-based, vegetables, fruits, legumes, things like that. And then, if I'm going to eat a meat, I make it a lean meat. If I'm going to eat other things, I make it chicken, or I make it a lot of fish, think Mediterranean diet, things like that. Smoking, I probably don't have to tell this group, but smoking really, I mean, the sooner you stop smoking, the better off you will be overall in terms of cancer recurrence, but also in terms of cardiovascular health. I think it's really important to know that you should limit, or better yet, completely cut out alcohol. I don't think anything good comes out of regular alcohol intake. And we know that many cancer recurrences are linked to the amount of alcohol that you drink. And we also know that any alcohol in excess of only a tiny bit is linked to elevated cardiovascular risk. Managing stress and getting the right amount of sleep also cannot be overstated. I always tell my patients it's important to empower them to know their own numbers. So know what your blood pressure is, know your cholesterol profile, know what your body mass index is, know what your sugars are, and know what your weight is. And if you have high blood pressure or you're worried that your blood pressure is too high, talk to your doctor about treating it. Same for cholesterol. It's important to maintain an ideal body weight. So if you are overweight or you are obese, we have tons and tons of options now for patients. Go to your primary care doctor, go to an endocrinologist, go to your physician or your medical team and talk to them about it, because you can see if you qualify for weight loss therapies or other, ways of other than what I talked about to lose weight and get to an ideal body weight. And I think most importantly, keep up with regular checkups. I think a lot of survivors, particularly of childhood cancer, fall into this trap of just being sick of medical care and being a part of the medical system. And I get that. But I think it's really important to see your medical team regularly. And if you aren't seeing a cardiologist as part of this team and you feel like you should, ask your oncologist or ask your primary care if that person thinks it's appropriate. And you can always just come in yourself. Step number 3 is watch for trouble. So it's nice, we have now ways that we know to prevent cardiovascular disease, but we can't prevent everything. So you should know what to watch for. So I put here sort of a chart because, as I'm sure you have all heard, men and women kind of present differently, sometimes the same, but often differently with cardiovascular disease. But suffice it to say, if you have any chest pain, any chest pressure, shortness of breath, nausea that isn't explained by something you ate, sweating, sudden cold sweat, lightheaded or dizziness that you can't explain some other way, A lot of women present with like a heartburn type of situation. I always tell women, do you ever feel like your bra is too tight, like that kind of feeling, even, just like an unexplained tightness in the chest or the mid underneath the breast area. All of those things should be taken with a lot of seriousness. And if you are concerned about anything, either go to the emergency room or talk to your doctor if it's happening. And remember, any symptoms can either be sort of like they can sneak up on you where they're mild at the beginning and then they can get worse, or they can be sudden. So just be aware of these symptoms because you need to alert someone if you're having them. And you need to get treatment if needed. So if your blood pressure is high, we have ways to treat this and we should be treating this. If your cholesterol is high, same thing. If you have diabetes or you have elevated sugar levels, someone should be helping you get those sugar levels down so you either don't become a diabetic, or if you are a diabetic, we have a lot of different medications now that prevent the diabetes from getting worse or also decrease your overall cardiac risk with diabetes. There are a lot of things that we can talk to you about in the office, like lifestyle modifications, a lot of which I talked about in the other slides, or medications for obesity, like we talked about. Sleep apnea, if you're a person that snores or you might be worried about having sleep apnea, that can lead to cardiovascular disease, especially in cancer survivors. So talk to your doctor about that. And always feel free to talk to your medical team about protective medications for the heart. Step 4 is to make a plan and really build your village. So I always tell people when they are survivors of cancer is a real time to kind of bring the forces together because you have survived cancer and now you are empowered to take care of your health for the rest of your life. So there needs to be coordination of care between your oncology team and your primary care team and maybe a cardiologist, someone like me, or even a general cardiologist who is used to seeing patients that have survived cancer. And prepare ahead of time so that if you're going to go to a cardiologist, you bring that person, or even your primary care, you bring that person a list of, what your cancer diagnosis was and what your treatment was. And if you don't have it, then you can always call the place where you got treated and ask them for a copy of your records, because I can tell you it makes it a lot easier for me to talk to patients in the office if I know exactly what cancer they had, what their treatments were. Even sometimes I need to know what the doses were of the chemotherapy. And it saves a lot of time and a lot of headache on my end and the patient end if I know these things when I walk into the room. So the more you can get of that before you meet with your doctor, the better. But also remember, you're the most important part of the team. So if you don't go and seek care, or if you don't, open up and ask your doctors whether or not this is appropriate for you, your doctors may not know that it's appropriate, and they may not send you to the right place. Exercise, we talked about before, and I cannot tell you what a huge proponent I am of exercise, but I will tell you a lot of people are looking this particularly through the lens of cancer survivorship. And while I'm not going to go into so much detail, suffice it to say that many groups have begun to really look at even the role of an exercise prescription. Going, for example, to cardiac rehabilitation or to a rehab medicine doctor and talking to them about specifically what exercise would work for you based on the type of cancer you had, based on what your limitations are, and really talking to the right people about getting into exercise, especially if you're not a person who is exercising before your cancer, during your cancer. It's important to get into it as soon as you can. It really, really helps. It helps with mental health. It helps with physical health. It helps with cancer recurrence and all of that. So really important to talk to your doctor about that too. I want to kind of briefly parlay into just a couple slides. I don't know if there's anyone on here who is a survivor of childhood cancer, but could be its own talk on its own. And I'm only going to spend a couple of minutes on it, but I think it's important for people in case there are survivors of cancer when they were kids or young adults. We know that in patients that had cancer when they were very young children or teenagers or young adults, that those patients are at particularly high risk of cardiovascular complication. It actually turns out that cardiovascular complications are the leading cause of death and morbidity in long-term survivors of childhood cancer, to the order of that childhood cancer survivors are 15 times more likely to have heart failure and 7 times more likely to have early blockages of the arteries compared to the general population of those that did not have a childhood cancer. And we know that actually the highest risk is in people that had radiation to the chest. It was called mediastinal radiation, or sometimes it was called mantle cell radiation. It was very high doses of radiation that really kind of go from almost like the chin and the neck all the way down to the belly button. And it was high doses of radiation. And we know that there's a strong dose dependence. So those who had higher doses of chemotherapy and those that had higher doses of radiation, and particularly those that had a combination of chemotherapy and radiation, are at the highest risk. And up to 60% of childhood survivors of cancer have had exposure to anthracycline chemotherapy and or radiation to the chest. And we also know that there's a long period of time, a long latency period between when, for example, a child got this cancer therapy and then they present to someone like me with heart failure or coronary disease. So it's important, if you're a survivor of childhood cancer or young adulthood cancer, or you know someone who is, that they are getting regular cardiac follow-up, because here especially an ounce of prevention is worth a pound of cure. It is very hard once you have cardiovascular disease to treat it and to really kind of get ahead of it. I will also tell you, and I think it's important to know, that as much as traditional risk factors like high blood pressure and high cholesterol are important for everyone, and if you have high blood pressure, you are at tremendously higher risk of having a heart attack or heart failure or a stroke or something like that. In patients who are survivors of childhood cancer, they are in a multiplicative way, meaning like several times the amount of risk. So you can see here, kind of without going into too much detail, a person who had high blood pressure and never had an anthracycline chemotherapy when they were a kid or a young adult has an odds ratio of around 34 times to have congestive heart failure. But if that person has high blood pressure and they got chemotherapy as a child or a young adult, they are 88%, right? They are 88 times more likely. So you go sort of 3 to 4 times as likely with versus without having a history of hypertension when you have had cancer therapy. And sort of the same kind of concept when you have had chest radiation. So if you have multiple risk factors, you are at risk of having coronary artery disease and you are at risk of having heart failure. But if you have multiple risk factors and you have had chest radiation, then you are significantly more likely to have coronary disease or heart failure. So especially in that population, controlling risk factors cannot be overstated. It is something that we feel very passionate about doing, which is why if you are one of these people, you need to be seen by a cardiologist. There are some guidelines for childhood survivors of cancer. I'm not going to go through them in detail, but I will tell you that it depends on what type of chemotherapy, how much of the chemotherapy you got, and whether or not you got radiation with it, like I kind of said before. And these guidelines then tell us how often we need to, for example, be screening with an echocardiogram. But I will tell you, when I see patients like this in my office, I am very, very hands-on with making sure that we're following them very closely over time with cardiac imaging and also labs, and making sure all their risk factors, their blood pressure, cholesterol, their diabetes numbers, their weight, are all under as good a control as I can make them. So what are the key takeaways? And then I promise we're almost done and we will hopefully have time for questions. Key takeaways: many cancer therapies can affect the heart. Survivors of adult and childhood cancers have a higher risk of cardiovascular disease in general. You need to know what your risk is, and you need to know the symptoms to watch out for. You also need to know what healthy habits look like for you, because they make a big, big difference. So try even to make small changes in your lifestyle. If you're not a person who walk for 20 minutes a day. If you're not a person who pays attention to how many vegetables and fruits are on your plate, do it tonight for dinner. Healthy habits make a very big difference. Make sure you're getting regular checkups with your primary care doctor, and make sure you're asking your primary care doctor if you're not seeing a cardiologist, if you should, because you are going to be your own best advocate. If you are still seeing an oncologist, ask your oncologist whether or not they think that it's important for you to see a cardiologist as part of your treatment plan or part of your survivorship plan. And remember that you're a survivor, so you should also be able to thrive. So we here at the NYU Cardio-Oncology program are here to help. And I'm always really happy to see patients. And actually, a lot of times from these survivorship webinars, we actually get patients that refer themselves because either their doctors don't think to, or they don't feel like they should. And I'm always happy to see patients that found me through a Facebook group or through a webinar. And we see those patients very regularly. And again, I'm happy to see patients even just for risk factor modification. If you want to know more about our program, we have a website that you can look up. You can just type in NYU Cardio-Oncology, or you can type in, Dr. Michelle Bloom, and it should come up. If you want to make an appointment to see me, this is the number. My secretary, Joanna Welsh, is wonderful, and she's more than happy to kind of get you in to see me. This is our cardio-oncology team. When I started here at the end of 2023, there were 2 of us that were heart failure cardiologists doing cardio-oncology and 3 general cardiologists. Actually, since I've joined, we have added 2 new cardio-oncologists. Actually, one, Dr. Chandrasekhar, is going to be starting next month, but one of them, Dr. Angie Seo, is seeing patients in the city once a week, and she's wonderful too for general cardiology. So you may wind up seeing me, or you may wind up seeing one of my colleagues, and we all are very dedicated to the practice of seeing patients who are survivors of cancer, who are active, patients with cancer who need cardiovascular care. And as Katie mentioned at the beginning, pretty soon after I got here and we started this program, we were awarded as a center of excellence for the care that we're providing to patients by the International Cardio-Oncology Society. We got a gold stamp of excellence, so we're pretty proud about that. So there are many, many resources. If you Google resources for patients who are survivors of cancer, a lot of things will come up online, and a lot of them are really wonderful resources. I put some of them here for you. The American Cancer Society has a lot of nice materials online. The International Cardio-Oncology Society has a specific page dedicated to patient education. Cancer.net and the National Institute of Health, the National Institute of Health, the NCI, National Cancer Institute, also has a lot of really, really nice informational stuff online for patients who are survivors of cancer. But certainly you should be engaging your doctors in conversation. And if you have a friend who's a survivor who's not on this call, you should also let them know about these resources. And then in case there's other medical providers, I also put on here resources for clinicians, including some of the same sites, but there are a lot of resources online that people can use in order to get more information on this topic that I didn't go through. So with that, I'm going to stop, and I'm more than happy to answer any questions. So then I wonder if you're following with our team anyway, or you're following with someone like me who's a heart failure cardiologist anyway, because I also take care of LVAD patients and transplant patients as part of my heart failure hat. Trastuzumab, which the trade name is Herceptin, and medications like it that we use for breast cancer, and actually oncologists are using now for other types of cancer as well. While the risk is relatively low, there is definitely a risk of cardiomyopathy, which is a weakening of the heart, and heart failure. And that's what it sounds like this person had and is asking a question about. So because we know that there's a risk of weakening of the heart and heart failure, albeit it's a relatively low risk, thankfully, what we do is we monitor people really carefully. And so everyone that is on one of these types of cancer treatments is expected to have an echocardiogram, which is an ultrasound of the heart, every 3 months. That sometimes changes based on other factors, but I would say for the most part, most people should be getting an echo every 3 months while they're getting the trastuzumab. And then sometimes even they need, longitudinal follow-up after. And those situations are, for example, if you've also had breast radiation, if you've also had other types of chemotherapy before or after, that could put you at risk of heart failure or cardiomyopathy. So it's hard to answer the question as sort of a black and white, because there's so many different things that go into how we decide, how to look for this. And of course, if we think that somebody has a weakening of the heart or heart failure, then we would need to treat them very aggressively. We would need to make sure they were on all the right medications, the medical therapy, to stabilize the heart function and hopefully prevent people from going on like this person who asked the question had to go onto a left ventricular assist device. But in most cases, we're able to prevent that from happening.
Great. Thank you. Are
So that's a great question, and that's something that comes up in my clinic, I would say about 100 times a day. Because the fact is that any patient with cancer probably has 10 different reasons at any given time to be tired. Okay. And fatigue in general for doctors is tough to tease out because fatigue can mean one of a lot of different things, or fatigue can mean the heart, or it can mean the lung, or it can mean that a person just isn't exercising enough, or it could mean a person is anemic, or it could mean a person is iron deficient. So there are so many different things that can cause fatigue in a general person. And then let alone when a person has had cancer treatment, is having ongoing cancer treatment, or who has survived cancer. So the quick answer to your question is you as a patient cannot know that unless you have an evaluation. So it could just be kind of a normal part of being a survivor, but you wouldn't know that unless you went to your doctor and you had proper testing. So whoever asked this question, I would highly encourage you to go to your primary care and ask that person, or if you have a cardiologist, go to that person and ask if you need other testing, because you should have blood work, you might need to have cardiac testing, and there's a lot of other testing that we do. I will say, for what it's worth, that once we've ruled out all of the things that it could be, if we think that it's just that a person who has survived cancer and been through a heck of a lot is tired, then those are people that I feel very passionate about getting you on an exercise program and getting you moving, because a lot of that fatigue can get better if you are put on a proper exercise regimen and you work your way up. But I think it's important at the beginning to make sure that there's nothing else going on. Another very good question. So I could probably spend an hour, Katie, to just talk about the risks and benefits of stem cell transplantation. But suffice it to say, the quick answer is yes. And what we do and what your oncologist will do before you ever even make it to a stem cell transplant, and we're involved in a lot of these cases, is to actually decide what the cardiovascular risk is, what the heart risk is going into the stem cell transplant, because there's a lot of things that we look at in a person's history and their file to tell us whether or not we think that a person is very high risk and maybe even shouldn't get a stem cell transplant, whether a person is high risk but can get the transplant, and so on and so forth, or whether we think a person is very low risk. And we work very closely with the oncologists who are doing the stem cell transplant to sort of understand this risk going in. But you have to understand that when a person goes through a stem cell transplant, there's a lot of changes to the body. There's a lot of things that can happen. We see a lot of patients during the time that they're getting the stem cell transplant can have rhythm issues. They can have heart failure because they get a lot of fluid administration. They can have, other types of situations go on with the heart. That's part of the reason why when you get a stem cell transplant, most patients are monitored for a long time in the hospital to look for these things. And it's also important after the stem cell transplant that you are seen both by your oncologist and, when it's appropriate, to be seen by a cardiologist or a cardio-oncologist because of that. That's a really great question, and I think it's a hard question to answer. So I'm gonna answer this way. I might be biased because I really think that if you can find a person who is a good cardio-oncologist, and you are particularly a person who is either very high risk of developing heart disease, or a person who already has heart disease and you had cancer and you had cancer treatment, I think that's the best case scenario. I think we're a little spoiled in New York and places like New York, because most places in the country don't have a cardio-oncology program as part of their cancer care. And most people don't have a cardio-oncologist that you can kind of call on the phone and say, hey, can I make an appointment to come in and see you? And I also think that there is something to be said for a good general cardiologist. And also, even at NYU, I didn't mention before, but we have a whole section of cardiology dedicated to preventive cardiology, meaning people that have risk factors like high blood pressure and high cholesterol and the things I mentioned before. And we have cardiologists that are actually really good at seeing those patients that don't yet have cardiac disease, but they've had a history of cancer and really honing in on risk factor modification. So I would say if you are in a place or you don't maybe have a general cardiologist that you have a comfort level with, then sure, go ahead and make an appointment with a cardio-oncologist. And that person will tell you if, they think you can be seen by a general cardiologist. Or if you are a person who is considered high risk, but you don't yet have cardiovascular disease. And for example, at NYU, you want to see the cardiac prevention team, they are fantastic. And I actually send a lot of patients there. If you are a person who has a cardiologist that you trust, or you have a recommendation for a good general cardiologist, I think that that's fine to start with, because if anything complicated happens and you have a good cardiologist, they should know that they can, send you my way or to one of my colleagues. And the fact is, there's not enough cardio-oncologists to go around in the country. So if you can't see a cardio-oncologist right away, I think it's totally legitimate to see a general cardiologist. I hope that answers the question. That's a good question that might not directly be related to my specialty per se. We do know in a very general sense that patients with cancer are at increased risk of clotting. So we know that your chance of having, for example, a blood clot in your legs or a blood clot in your lungs or a blood clot, at the site of your port or something like that is higher when you have cancer. So that is something that I would definitely have this person talk to their oncologist about. Um, Whether or not it's related to heart disease is a little hard to answer that question without knowing more about the person's specific cardiac risk. So I think for that question, probably best to go back and ask your oncologist, because it's hard without more information to really give a good answer. Really good questions. So again, but just to keep this talk to a shorter time frame, when I give this talk to other doctors, I usually go through kind of each by different cancer type and also by cancer treatment type, because you could have an entire hour spent on hormone therapies for breast cancer and for prostate cancer. But the short answer is yes. When we know that we're putting people on hormone interrupters, either for breast cancer or for prostate cancer, we know that those can increase cardiovascular risk. Why? Because we're interrupting the normal pathway of hormones, which sometimes can be protective against cardiovascular disease. So it's this kind of like, to just take breast cancer as an example. In a woman who's premenopausal, she has high levels of circulating estrogen. When you become perimenopausal and then postmenopausal and you lose your estrogen supply, that increases risk of cardiovascular disease. So you can imagine if I am actually inducing early menopause because of some of the hormone therapies like the aromatase inhibitors for a breast cancer patient, I am inducing early menopause and I am decreasing the amount of circulating estrogen to decrease the risk of the cancer coming back. But with that actually comes a risk of increased and earlier cardiovascular disease, increased risk of cholesterol abnormalities, high blood pressure, and things like that. The person asked about prostate cancer therapies. The short answer is yes. When I'm interrupting the hormone pathways for a prostate cancer patient, that definitely increases something called a metabolic syndrome, obesity, central adiposity, like fat in the belly area, increases cholesterol levels, increases propensity for high blood pressure and diabetes and all of those things. So I think it makes it that much more important to talk to your oncologist and also talk to your primary care or your cardiologist about how to decrease those risks in those types of cancer treatments. Yes. A little general for me to answer specifics. I would say in a very general way, like I said before, if you're not a person who has seen a cardiologist and you worry that you might be at an increased risk, I think it's totally legitimate to go to your oncologist and say, look, I heard a lecture on cardiovascular complications from cancer treatment, do you think I'm at an increased risk? And do you think that you think I might benefit from seeing a cardiologist? It's hard to answer that question without knowing specifically what treatments they got. Because when we see a patient, we very much look back and we see not only what the traditional cardiac risk factors are, but also what treatment they got. And we kind of put that all into this formula in our brains and we decide what we think the cardiovascular risk is. So without having too many details, it's hard for me to say definitely yes. But I would say if you're on the fence and you're wondering, ask your oncologist or make an appointment with a cardiologist and ask. The simple answer is no, because anyone that needs a TAVR needs a very extensive evaluation. There are so many things that go into our decisions about whether or not a person is a candidate for a TAVR. And some of them are cancer related, but to be perfectly honest with you, a lot of them have nothing to do with the cancer. And they have more to do with what the aortic valve looks like when we look at the pictures of the aortic valve, how much calcium is on the valve, a patient's other medical conditions, how frail they are, and so many other things. So you can never make a blanket statement. Yes, if I need an aortic valve replacement, yes, I'm definitely a candidate for a TAVR. That said, we have a really, really great TAVR team at NYU. And so when I have a patient who needs their aortic valve to be looked at, because I think that the person might need an aortic valve replacement, I send them over to our TAVR team and I do my assessment, but I also really rely heavily on that team in order to make a judgment call on whether or not that person is appropriate for a TAVR. So I think it's for a lot of the reasons why we talked about in those slides that I showed you on childhood survivors of cancer, which is that a lot of Hodgkin's lymphoma survivors have gotten very high doses of a chemotherapy called an anthracycline, which we know in and of itself when we give those types of chemotherapies, they particularly predispose patients to a weakening of the heart because the way the chemotherapy actually works, it actually gets confused when it enters heart cells. It's designed to kill cancer cells, but what happens inadvertently is sometimes it actually kills some of the heart cells and makes the heart function poor. And then on top of that, many patients that get Hodgkin's lymphoma also need to get radiation to the chest. And I showed you before in those slides that when you have chemotherapy plus radiation therapy, and especially if you have other risk factors, that way increases your risk of getting cardiovascular disease. So I think it's a lot of different factors. I think it is mostly to do with that those patients wind up getting higher doses of anthracyclines. Those patients are more likely to have radiation to the chest. They're more likely to have the combination of the two. And also, I will say, in fairness, Hodgkin's lymphoma is a very treatable cancer. So thankfully, we have a lot of people that are survivors for many, many years. And as you age, you have increased risk of cardiovascular disease anyway. So those people that have gotten those kind of hits against their heart and then they age and they have other risk factors for heart disease, it's sort of the perfect storm. So by the time we wind up seeing those patients years and decades later, they are at increased risk above the general population.